patients will also turn happy. Stay positive and keep smiling. Always stay in bliss. With these beautiful lines, I wish everyone a very beautiful good evening. Now, it's time to begin our second technical session of day 2, ICHW 2021. Our next speaker, our first speaker of this evening session is already amongst us. Spinal disorders are the most frequent cause for the doctor's visit worldwide. A very, very known fact. And to enlighten us on the subject, we have with us the well-renowned and finest resource person from the beautiful country of Nepal, Dr. Sunil Paudel. Dr. Sunil is world's first naturopathic and pain physician with his expertise on spine. Post BNY, he did his postgraduate diploma in pain management from UK, fellowship in pain management from Harvard, USA. He is the ex-owner, founder, director, Prana Spa USA, founder of 10 hospitals, more than 20 spas, wellness clinics around US Virgin Islands, British Virgin Islands, Kathmandu, etc. Today, he will be sharing his expert knowledge of versus integrated naturopathic medicine management for lumbar spinal stenosis, KCE. I welcome you, sir, and invite you to share your expert knowledge.
Thank you very much. Thank you for inviting me to this conference. Yeah, truly well said. Spinal disorders are the most frequent cause for doctor's visit. It's not headache, it's not common cold, or it's not neither fever for doctors frequent visit. It's spinal disorders. So the spinal pain, any disorders related with spine are so frequent. We are evolving as a human being. We are not used to sitting at one place, but because of the technology and in this new era, we have to sit. Everything happens sitting. Earlier, when we had to do, we had to cook food, we had to go and cultivate few hundred years back. Okay, we had to cultivate, we had to put water to those plants, we had to yield all those crops, we had to go miles for water and any food. Nowadays, everything happens with just your cell phone, just sitting. So that's creating tremendous pressure in the spine, and it's nothing but posture that's causing all these disorders. Okay, so it's a long session today. So without wasting any time, let me share my screen. I hope it's visible. Is it?
Yes, sir. It is.
Okay. So today we are discussing about surgery versus integrative naturopathy for lumbar spinal stenosis. Lumbar spinal stenosis, one of the most frequent cause for back pain, mainly low back pain. Okay. So we'll discuss what is lumbar spinal stenosis and what are the management protocols. Lots of us might be treating low back pain and lumbar spinal stenosis even without knowing what we are treating. Okay, so naturopathy is very effective in this, though there has not been any research, because most of, as I told you, most of us are managing it without even knowing it. Okay, so let's go and learn what lumbar spinal stenosis is. Okay, so it refers to the narrowing of the spinal canal, okay, leading to compression of the neurovascular bundle due to many causes. The most frequent causes being the disc herniation, what we call disc prolapse, okay, slip disc, all these things. It's all the same. Slip disc or disc herniation or disc prolapse are all the same. So the lumbar spinal stenosis, the prevalence is around 11% of the general population. That's a huge number. Okay, so this is the spinal canal. Okay, so in the spine, at the back, at the posterior side of the vertebra, we have got a triangular canal, what we call spinal canal. Okay, so in lumbar area, this canal is called lumbar spinal canal. Okay, this is also called central canal. Many literature or many experts, many specialists speak it in many terms. Okay, so this is normal canal, and when there is narrowing, okay, there might be many causes narrowing this spinal canal. Okay, so any causes in this image, in this graphic image, as we can see on the left, this is because of the osteophyte over here at L3. This is the posterior end plate osteophyte compressing the spinal canal. Okay, so over here, there is this osteophyte could be because of lumbar spondylosis, could be other causes, other inflammatory diseases as well. And over here we can see spinal stenosis behind in the spinal canal in L4 vertebra and at L5 as well. Okay, so those people who are used to seeing MRIs, it's very easy to identify. So this is graphic image, same thing I'm showing you over here in an MRI. This is T2 sagittal MRI. So over here we can see this is over here there is slight listhesis, you can say grade 1 enterolisthesis of this vertebra, and then we can see there is swelling of ligamentum flavi over here, what we call hypertrophic ligamentum flavi. Okay, so there is listhesis, slight pseudo protrusion. Okay, this is called pseudo protrusion. Those people who have already joined our spinal diagnosis and management course, it will be very easy. Those people who are used to seeing an MRI, it will be easy. For those, you can learn, keep learning, no problem. So the spinal stenosis, the cause of spinal stenosis in this case is pseudoprotrusion, enterolisthesis, and the ligamentum flavi hypertrophy. Okay, there might be many causes, but today we are going into the most frequent cause, that is disc herniation, what we call slip disc. Very frequent cause of spinal stenosis. Okay, so I'm showing you a graphic image again. Okay, this is the left half of the image is healthy one and right half is unhealthy. So I'm showing you what and all can cause lumbar spinal stenosis. So over here, this is very healthy spinal cord over here on the left, and on the right side you can see the spinal canal is compressed slightly. So over here we can see disc protrusion can cause, because disc protrusion posterocentral or posterolateral, paramedian, what we call paracentral as well. So all this disc protrusion can cause spinal stenosis, okay, or the narrowing of the spinal canal. So over here disc protrusion can cause that, mainly posterocentral, and paramedian, what we call paracentral as well. So that can cause spinal stenosis. And then there is something called ligamentum flavi over here at the posterior rim, okay, at the posterior arch of our vertebrae. So this ligamentum, any hypertrophy or calcification of ligamentum flavi over here can also cause spinal stenosis. And there is called PLL, posterior longitudinal ligament over here. So if posterior longitudinal ligament gets calcified or gets hypertrophied, that also can lead to spinal canal stenosis. Then sometimes arthritis or inflammatory arthritis, spondyloarthropathy, what we call ankylosing spondylitis, all these things can also cause large osteophytes. So osteophytes also can encroach into the spinal canal. Okay, so that can also lead to spinal stenosis. But remember, the most frequent cause in our country or elsewhere all around the world is disc prolapse, or what we call slip disc. Disc herniation is the technical term. Okay, so on the left side, this is normal spinal canal, lumbar spinal canal. This is normal lumbar spinal canal, as you can see in this MRI. This is T2 axial view, what we call transverse view as well. So this is the stenosis. So over here, same thing I'm showing you, the same thing, that same graphic image. Over here it's clear, you can see the thecal sac and you can see the nerve roots, beautiful. Okay, you can see epidural fat, a beautiful bean shaped disc. This what we would want to see in an MRI. This is posterior side and this is anterior. Okay, this is front and this is back. So this is the spinal canal and this is the thecal sac. This is where the nerve roots are playing around over here. The nerve roots reside over here. Okay, these are the neural foramina, and neural foramina don't count into spinal stenosis. That's lateral canal stenosis or foraminal stenosis. So this area is the spinal canal. This triangular area, as you can see, is the spinal canal, and many causes can lead to spinal stenosis. So let's see one of our patient's image. So over here, what we can see, this is posterocentral and bilateral paramedian disc protrusion. So can you see this white spinal canal? This is T2 image. T2 image shows the S2O, water, and the fat white. Okay, so anything you see in these two images that are white are either water or fat. Okay, if you have joined our spinal diagnosis and management course, it will be a piece of cake for you, because this is what we teach. So over here, what we see, you can see this black, dark, okay, what we call hypointense. Okay, this shadow, hypointense shadow, this is ligamentum flavi. So over here, ligamentum flavi is also compressing the spinal canal from either side, and there is disc protrusion, that's for sure, right? Disc protrusion is pressing it from anteriorly, and ligamentum flavi is pressing it from posteriorly. That is leading it to spinal canal stenosis, and this person is suffering from severe spinal canal stenosis, moderate or moderate to severe. We cannot see thecal sac, we cannot see nerve roots. So the moment we cannot see nerve roots and thecal sac, that's severe spinal canal stenosis. And we can see there is facet arthrosis as well. So that's also leading to lateral recess, and that's leading to lateral recess and also foraminal stenosis. But we are going into spinal canal stenosis. We cannot see the thecal sac, we cannot see the nerve roots. So this is pure spinal canal stenosis over here. I'm not going into depth. In depth, we'll study and we'll learn in our sessions. So what are the signs and symptoms? How it is characterized? So lumbar spinal stenosis is characterized by low back pain. Yes, LBP. Okay, low back pain is one of the most frequent cause, and that's not it. Okay, radicular pain. Okay, radicular pain means sciatic kind of pain. The pain goes to the leg. The pain always should go to the leg. One, unilateral or bilateral, doesn't matter. Okay, depending upon the disc herniation, unilateral or bilateral. So the radicular pain, the sciatic radicular pain is nothing but sciatic kind of pain, gets aggravated by walking, standing. That's called extension. If the pain gets aggravated by extension, that means you can suspect lumbar spinal stenosis, and it needs to be relieved by sitting or flexion. The moment the sciatic pain gets relieved with flexion, that could be lumbar spinal stenosis. And not only that, okay, low back pain, sciatic kind of pain that gets aggravated by extension or walking, standing, and gets better on flexion or sitting. Okay, not only that, it limits mobility and it reduces balance capabilities as well. Okay, so these are typical. The moment the lady stands and walks, okay, or straightens her back, so that provokes the symptom, the sciatic kind of symptom. The moment she starts bending forward, that's why any patient coming to you by bending forward, walking, bending forward, you need to be suspecting lumbar spinal stenosis. So that's why they bend forward to walk. Okay, and they feel even better while sitting. This is typical presentation. And as we know, lumbar spinal stenosis is a major public health and socio-economic problem that is associated with poorest quality of life. Okay, amongst all musculoskeletal disorders, lumbar spinal stenosis is one of the major reason, okay, for poorest quality of life, and this can easily lead to disability. We have seen thousands of patients in our clinic and hospitals with disability and even paralysis. Okay, so lumbar spinal stenosis is one of the most common causes of non-traumatic spinal cord injuries as well. Okay, spinal cord injuries are of many kind. One of them is non-traumatic spinal cord injuries. This is one of the most frequent cause of non-traumatic spinal cord injuries. So lumbar spinal stenosis symptoms usually start slowly and get worse over time. So the onset is always gradual, not sudden onset. Usually sudden onset can be there, but rare, only in acute disc herniations. It could be acute as well. So there will be neurogenic claudication. What you call neurogenic claudication is the sciatic kind of pain while standing or walking. Okay, mainly in walking, when you get pain in your legs, tightness in your legs while walking, that's neurogenic claudication. So it's not vascular. So neurological deficits are very common. And the disability, can you focus on disability? Up to 43% of the patients report some weakness of lower limbs. That's a huge number. You cannot see it anywhere else. So lumbar spinal stenosis is one of the leading cause of disability. Lumbar spinal stenosis also has high potential to develop cauda equina or conus medullaris syndrome that requires immediate surgery. Okay, so the diagnosis of lumbar spinal stenosis is made on history taking, physical, and radiological examination. In our spinal diagnosis and management sessions, we teach you how to see MRIs, how to do physical, orthopedic, and neurological examination, how to see X-rays, everything. So this is how there are lots of tests. I'm not going into tests. So there are lots of tests. So we do physical, orthopedic, and neurological examination and diagnose spinal stenosis. So on radiological, the gold standard is an MRI. Okay, higher the Tesla, better. Okay, if 3 Tesla MRI is available, that's fantastic because it allows you to see the nerves easily. So this is one more. I'm repeating the MRI. Okay, T2 sagittal view and T2 axial or transverse view. So that shows spinal stenosis over here. So what about the management part? Modern medical management for lumbar spinal stenosis are not very effective and they are often unsatisfactory. Okay, this is a bitter truth. No matter whether it is medication or surgery, modern medical managements have not been up to the point at all. Okay, so lumbar spinal stenosis is major reason for surgery and failed back surgery syndrome. Usually we used to use this term FBSS, failed back surgery syndrome, but nowadays it is called post-surgical spine syndrome as well. Okay, so you need to be very aware that there is the modern medical management has almost failed in most of the cases. I'm not saying that you can refer to these researches. The references are given below in blue, okay, in all slides. So even in my practice, I see lots of spinal stenosis patients that are not happy with surgeons, that are not happy with orthopedics or neurologists. They come to me frequently. I see at least 15 to 20% every day. Okay, so major lumbar spinal stenosis also is the major reason for surgery and also major reason for failed back surgery syndrome. Okay, and the efficacy of various kind of surgeries treating lumbar spinal stenosis remains unclear. So among these references, there are meta-analysis and systematic reviews as well. Okay, so what do those meta-analysis say? The various kind of surgery, efficacy of the various kind of surgery in treating lumbar spinal stenosis remains unclear till now. Okay, results of many high quality studies and large scale systematic reviews are inconclusive. Remember, inconclusive. So before referring a patient for surgery, remember, are you going to spoil that patient? Are you going to spoil, are you playing with that patient's life? Because there are chances it might fail. So surgery complications are frequent and dreadful. Okay, this is what the researchers say, and this is what I see every day. Let's see some patients. But why do people go for surgery? Okay, the major reason why do people go for surgery is poor pain management. They cannot manage the pain. Okay, poor knowledge of pain management amongst the specialists. Even the surgeons don't know how to manage the pain, and they are least interested. That's not how they are going to make money, are they? Okay, that's not their expertise as well. So lack of human resource in pain management in tertiary care hospital or secondary care hospital is also one of the reasons. Once you don't have got anyone managing your pain, then it might become difficult. and it creates fear amongst patients and doctors. Okay, I in my clinical practice, I don't like the patient who come to me, I get back pain and I get pain while doing this and that. I love the patient who tell me, doctor, can you kill me, my pain is that much. Okay, I love those kind of patients, I love that kind of challenge, and they are, believe me, they are very easy to manage if we know. Okay, so fear amongst the patient and as well as among the doctor. Okay, we might feel, oh, maybe it might lead to cauda equina, it might lead to paralysis. Believe me, it's very easy. Okay, so fear amongst the patient and as well as amongst the doctor is one of the reason, because we are not educated, even doctors are not educated, lots of surgeons don't know it can be managed very easily. Okay, and the hospitals are dominated by surgeons, that is another reason people go for surgery. Okay, most of the hospitals, who are the most famous doctors? Surgeons. Okay, and why patient go for surgery? Because of the fear and because they are unable to bear pain during first week or first fortnight. If you can bear the pain for 15 days, no one would like to go under knife. Okay, no one would like to go for surgery. So pain management allows me to manage their pain, and their belief on me also is another thing, because the pain management increases that, enhances the belief as well. Lack of training and courses in this subject as well. There is not even single course developed in spinal diagnosis and pain management all around the world. Okay, people learn thousands of things, but they don't learn the basics. It's very easy, but there are not many courses. Lack of robust conservative protocol. All over the world, I've seen there is lack of robust conservative protocol. There have been thousands of research I showed you, but there have been very lack of robust conservative protocol. And the guidelines, our guidelines, red flags, yellow flags protocols, our guidelines are outdated. They are outdated. That's another reason they will have to go under surgery and fail. Okay, so I am showing you, I'm giving you reference a few hundreds. There are, I've got more than 100 researches that say, that justify Nakamson's, AL Nakamson's conclusion. Okay, so in Acta Orthopedica Scandinavia, so he has mentioned clearly that never go for surgery without exhausting extensive conservative management. Because why? Because surgery is no better than conservative management. Okay, it's not only my experience, also all these hundreds of researchers, that's what they tell. Never go for surgery without exhausting extensive conservative management. Okay, so and then people go for surgery, and there is repeated spinal surgery is repeated as well. Okay, so I'm referring to failed back surgery syndrome, a review article in Asian Spinal Journal recently. Okay, it was 2018 research. It says around 50% of the primary surgeries, first spinal surgeries, are successful. Around 50% are only successful. No more than, and you know, this prolapse spinal stenosis is caused by posture. The surgeon is not going to teach you how to maintain your posture, and it comes back again. So no more than 30% of second surgery will be successful. No more than 15% of third surgery will be successful, and no more than 5% of the fourth surgery will be successful. Can you see? It's a least number. So why do you send patient to surgery? Because we don't know. We are not educated in this field. Okay. So efficacy of integrative multimodal conservative management has been proven in multiple studies. There are multiple studies that has proven that integrative multimodal conservative management is successful. Without surgeries, we can successfully treat spinal stenosis. But there has not been even one study with yoga and nature care approach. Okay, that's so unfortunate. But I've been treating since more than 15 years. I've been treating spinal stenosis with integrative naturopathic approach, and believe me, I'll show you a few cases. Okay, it is very successful. We can treat lots of patients. Okay, so this is so let's go and find out few cases. Let's So this is all about not researches and me teaching you. That we'll do somewhere later. So for the timing, let me teach you. Let's discuss few cases. Okay. For the timing today, I've got 4 cases. I've got hundreds of like this. Okay, more than hundreds. So the first case is surgery case. This lady, okay, who didn't want her name to be revealed, went to a most famous neurosurgeon over here, and she was diagnosed with spinal canal stenosis at L4, L3, L4, L4, L5. Okay, and this is the diagnosis discharge with what was she done? Multi-level laminectomy. So what is laminectomy? I'm not going to teach you. We don't have got much time. So there is something wrong over here. The surgeon did something wrong. Okay, what did he do? Okay, the pain was little bit too much in last 10 to 12 days. Okay, she had got sciatic kind of pain, but it was little bit more in last 10 to 12 days. So what Nakamson told us, okay, never go for surgery without exhausting extensive conservative management. The surgeon didn't think so, so the surgeon operated because that's what they know, right? And as I told you, hospitals are dominated by surgeons. She went for multi-level laminectomy. This is her case history. Okay, and as I will focus you, okay, I'll focus where the case history, unable to walk, stand, and she is wheelchair bound. Okay, and this is post-surgical evaluation. Okay, during post-surgical evaluation, she told me clearly surgery was a failure. The next day on, she could never walk, she could never stand, and she is wheelchair ridden. It is by no means ridiculing surgery or anything. I'm just educating you. Okay, so I don't mean to say something is superior, something is inferior. Okay, so we are trying, let's try to have a balanced view. And before surgery, she could do her daily duties, work or walk, or okay, but she is not able to do it all. And now she has developed frequent falls also. Okay, so what was the thing? Okay, let's go into pre and post surgical MRIs now. I evaluated her MRIs again. So this was 2019 pre-surgical evaluation. We can see this is L543. These are all T2 sagittal images. Okay, very clear to tell you. You can see L34, there is posterocentral disc herniation. L45, there is posterocentral disc herniation, and there is spinal stenosis. Okay, so this is pre-surgical and post-surgical. You can see again. Can you see over here? The spinal stenosis again the same. So the approach was wrong. Could be the surgery doesn't clean up all the spinal canal space at all. It is impossible because that space is something like that. It is difficult, very difficult to clean that up. So despite of his best effort, see, the surgery was totally failure 2019, and in 2021 it looks even worse. Can you focus? I have focused over here. L34, L45. Okay, L34, L45. So the surgery was a failure. Disc herniation is still exists. Spinal canal stenosis still exists. Okay, now let me show you another thing. So this is L45. Okay, there was no listhesis at all. Now this was pre-surgical 2019. Now in post-surgical, can you see over here? Post-surgical, you can see there is enterolisthesis of L4 over L5, grade 1. So she came to me with disability. So this is, so that's what, she was unable to walk, stand, wheelchair ridden after surgery because it was a failed back surgery. So what she would do? She would go for another surgery. The success rate as Asian Spine Journal says, success rate second surgery 30%, third surgery 15%, fourth surgery 5%. Okay, she did not go for surgery. She came for rehab. Okay, now there was a gentleman who is rich and he went for 3 surgeries. So this is the surgery scarf. This is the gentleman. So let's go and see him. Okay, so the first surgery was done in 2001. Okay, and second surgery was done in 2008. and he was not happy with the outcome. Then he went to Delhi for third surgery. Okay, now can you see? Let's see this patient. Okay, let's see this patient. How does he do with third surgery, after third surgery? Okay, so let's see a quick video. So you can see his foot drop. Okay, bilateral foot drop. He cannot walk without stick. Very difficult to walk without stick. In next video, I'll show you how does he walk without stick. Okay, see, this is how he walks without stick. Very difficult. There is radiation still, and basically he cannot walk more than few steps. This is the disability he has gone into after 3 surgeries. Okay, so as I told you, there are motor deficits, gait problem. Okay, his muscle power is around 2, and he has got urge incontinence. Uh, he cannot control his urine. This is the result of surgery. This is what we are looking for. No. Okay, so then let's see, we saw a few post-surgical cases. Let's go into integrative naturopathic management. L4-5 severe herniated lumbar disc with grade 4 caudal migration. Okay, I'm focusing on before and after. Okay, so after integrative management, this was the case at L4-5. There was huge balloon, large posterocentral disc prolapse, disc herniation with caudal migration. Can you see inferior migration of the disc fragment? And this is after the integrative naturopathic management. Okay, this is after integrative naturopathic management. And these are T2 sagittal images, and these are T2 axial image. Can you see this fragment? This fragment is totally lost over here after integrative naturopathic treatment. Okay, so this is the radiologist report. Okay, so he has given, the radiologist has given totally comprehensive comparative report, and the report says only a small rudimentary caudally migrated component is seen in the current study, and there is no nerve root compression seen in current study. This is post naturopathic rehab. Okay, so the patient was totally cured. Okay, pain scale, okay, numeric pain rating scale was 0, no radiation, no paresthesia, neurology was normal, functional ability fantastic, totally normal. Okay, as we are out of time, I'm doing it slightly quick. Okay, so let's go for case 4. Okay, what about the lumbar spinal stenosis patient with paralysis? Okay, this was without paralysis. This case was without paralysis, though disc prolapse, disc herniation was huge. So let's see a patient with paralysis treated with naturopathic approach. Okay, so this is a patient. Okay, he gave his consent, so I'm giving his name. Okay, so I'm not going into case history. I straight away, let's see the MRI. So there are disc disease in L3-4, L4-5, L5S1. So over here we can see more at L4-5 and L5S1 with spinal canal stenosis. Right over here you can see the disc fragment in the spinal canal. Okay, so let's see the patient. How did he come to me? Okay, I'm pausing over here. You can see, you can focus on the toes. He cannot extend his toe. I'm doing heel walk test. Okay, he is not able to extend his toe. Okay, let's see on the right foot. So dorsiflexors are also weak. You can see dorsiflexors are also weak. He is not able to take his toe up. Okay, dorsiflexors are weak. Extensor hallucis longus is also weak. Okay, so and I asked him to walk on the toe now, toe walking. Can you see how he limps? It's because of the weakness of the plantar flexors. The calf muscles are paralyzed. Okay, that's the reason. Okay, so this is the patient after 2.5 months. The same patient walking fantastic on toe walk, heel walk, nothing bothers him. Okay, he can walk on the toe, he can walk on the heel, no problem at all. Okay, even paralyzed patients after spinal stenosis can be cured with integrative naturopathic approach. Okay, let's just conclude now. We don't have, but we are out of time, so let's just conclude. So he was totally cured. His NPRS pain scale was 8, now 0. Radiation severe, none. Paresthesia, none. Neurological deficit, no. Functional ability is normal. He's working in his shop. Heel and toe walk, normal. So okay, so what were the protocol? The protocol were counseling, because it is the confidence within you that is going to convince the patient. Conservative pain management, SOS. If the patient comes to you with severe pain, we can manage with that pain management for a few days. Postural care, rest in specific poses. There are specific poses I have postulated that help to not only in pain management, also in treatment. Specific yoga and exercises, physical therapy modalities, manual therapy and adjustment, massages, acupuncture, hydrotherapy modalities. Okay, unloaded harness walking therapy, electric muscle stimulation, supplement and herbs, and the admission. How long it might take? 1 week to 1 month. These patients were treated for 1 month in admission, and he was coming twice a week for 2 months. Okay, before he was cured. So in future, I'll be coming up with a book on all these evidences, spine care, and we might be getting a course to you as soon as possible as well. Okay.
Thank you, sir. So as we are running short of time, so
Yeah.
here will be concluding with it.
Okay. Yeah.
You have really entitled as practically how we can deal spine cases without even thinking about surgery, because once people are in pain, the first line of treatment they go and think about is managing through surgery or anything. So it gives more confidence in all. Thank you, sir, for your very informative session and your valuable time.
Yeah. Thank you very much.